So chronic myeloid leukemia. Now, chronic myeloid leukemia it is a leukemia of cells, and myeloid cells, but myas they include eosinophil. It is important to remember because it will help us in differentiating between CML and CLL. So now let's discuss chronic myeloid leukemia. Remember that chronic myeloid leukemia, it is present in 95% of the patient. Philadelphia chromosome is present in 95% of the patient with chronic myeloid leukemia. Philadelphia chromosome can also be present in ALL as well. About 15% of the patients of ALL, Philadelphia chromosome can be present. The presence of Philadelphia chromosome in both of these leukemias is a poor prognostic factor. Remember that. But the Philadelphia chromosome it is more common in chronic myeloid leukemia. It is present in almost 95% of the patient with chronic myeloid leukemia. What is a Philadelphia chromosome? Philadelphia chromosome is a translocation between the long arm of chromosome 9 and 22. The ABL proto-oncogenes from chromosome number 9, it is translocated to chromosome number 22 and fused with BCR gene. This fusion of BCR and ABL is Philadelphia chromosome, which result in the excessive proliferation of white blood cells and result in chronic myeloid leukemia. So in chronic myeloid leukemia, there is excessive proliferation of white blood cells such as neutrophils, eosinophils, and basophils. CML normally progresses through 3 stages. There is a chronic phase, there is an accelerated phase, and there is blast crisis or blastic phase. Most of the patient, 90% of the patients will present with chronic phase. So you need only to focus on this chronic phase because this is a common presentation of chronic myeloid leukemia. In some patients, in about 5% of the patient, this chronic phase, it can change into blast crisis or blastic phase, in which there will be blast cells formation in CML as well. But for Plab1, you need to remember the chronic phase and its presentation. What is the presentation of CML? Anemia, weight loss, and night sweating are common. Remember that because of excessive proliferation of white blood cells, there is a massive splenomegaly. So whenever you see a massive spleen or a spleen that is massively enlarged, you will think about two diseases again for Plab1. One is CML, crazy massive large spleen, mnemonic, and the second is malaria. Malaria can also cause massive splenomegaly, but in malaria there will be a history of travel to Africa, and in CML there will be no such history. So massive splenomegaly in Plab1 will always be either CML or malaria. Now this point is important, that a peripheral blood film in case of CML, it will show spectrum of myeloid cells. A peripheral blood film will show a spectrum of myeloid cells, and myeloid cells, they include neutrophils, eosinophils, and basophils. Spectrum means all stages of maturation will be present. All stages of maturation of neutrophils, eosinophils, and basophils, they will be present in a peripheral blood film. So if a peripheral blood, a patient, an old age patient whose age is above 40 or above 50, he present to you with high white cell count. White cell count is usually more than 100. And a peripheral blood film shows all stages of maturation of neutrophils or myeloid cells, then it will be CML. And if a peripheral blood film shows mature lymphocytes and not myeloid cells such as neutrophils, then it will be CLL, chronic lymphocytic leukemia. So this is the first differentiating point between CML and CLL. That in CML, a peripheral blood film will show myeloid cells such as neutrophils, basophils, and eosinophils at all stages of maturation, while in CLL, peripheral film will show lymphocytes. Hepatomegaly can be present in both.
Sorry, can you say that again, please?
Uh, for CML and CLL, an important differentiating point on a peripheral blood film is that, as their name indicate, CML is a myeloid leukemia. So a peripheral blood will show myeloid cells such as neutrophils, eosinophils, and basophils at all stages of maturation, while lymphocytic leukemia, CLL, will show lymphocytes on a peripheral blood film. Is it clear now?
Yes.
So remember that because it's a myeloid leukemia, so lymphadenopathy or enlarged lymph nodes is very rare. So lymphadenopathy is rare. While in lymphocytic leukemia, because it's a lymphocytic leukemia, and there is in lymphocytic leukemia there is proliferation of mature lymphocytes, and lymph nodes is a home for lymphocytes. So in lymphocytic leukemia, lymphadenopathy is common. So high WBC count or white cell count with no lymphadenopathy, the most likely diagnosis will be CML, chronic myelocytic leukemia or chronic myeloid leukemia. And high white cell count with lymphadenopathy, the diagnosis will most likely be lymphocytic leukemia. In 5% of the cases, chronic myeloid leukemia can transform into acute myeloid leukemia. And you all know that what is acute myeloid leukemia. In acute myeloid leukemia, there will be blast cells on the bone marrow. So the investigation is when you will suspect chronic myeloid leukemia or chronic lymphocytic leukemia. If on a full blood count, there is leukocytosis, that is a white cell count of more than 100 into 10 raised to power 9 per liter, then you will suspect chronic leukemia, either CML or CLL, because both of them will present with a high WBC count. While we saw in acute leukemias that acute leukemias present with features of pancytopenia, because the blast cells, they can suppress the formation of uh, the other cell line. So acute leukemia will present with features of pancytopenia, and because chronic leukemias, they are cancer of mature or differentiated cells, so that's why they will present with high WBC count. So full blood count will show high WBC count, and differential shows granulocytes at all stages of development. Increased number of neutrophils, myelocytes, basophils, eosinophils. So the initial diagnosis can be made on the basis of a full blood count and a peripheral blood smear. High WBC count, which shows granulocytes, such as increased number of neutrophils, basophils, and eosinophils, then the diagnosis will be CML, myeloid leukemia, because there is increase of myeloid cells. Bone marrow biopsy is also done in chronic leukemias to quantify the percentages of blasts and basophils, because
So
there
in
are some blasts.
CLL, there won't be splenomegaly because of no pancytopenia. Sorry, no. The granulocytes, they are not increased, so there won't be splenomegaly in CLL.
In CLL, because lymphocytes also reside in the spleen, so there will be splenomegaly, but the splenomegaly will not that much remarkable.
Right.
There can be mild splenomegaly.
Right.
Hepatosplenomegaly, they can be present in all type of leukemias, but
Right.
they are more common to some cancers.
Okay.
And some even causes massive splenomegaly due to excessive proliferation of these white blood cells, such as CML.
Okay.
And sometimes it's a presenting features of a CML, that a person present to you with massive splenomegaly and there are no other sign and symptoms. So
Right.
you need to remember this massive splenomegaly is specifically with CML or chronic myeloid leukemia.
Right.
So bone marrow aspiration is done to quantify the percentage of blast cells and to assess the degree of fibrosis, and also for cytogenetics to the characteristic features in CML is Philadelphia chromosome. It is found around 90 or 95% of the cases. So that's why initial investigation is full blood count with a peripheral blood smear, and the definitive one is bone marrow biopsy. Management is chemotherapy in the form of imatinib, hydroxyurea, interferon alpha, etc. So what are the specific points that you need to remember in relation to CML? And they include WBC count, and differential will show granulocytes at all stages of development without blast cells. So primarily there will be increase in the granulocytes such as neutrophils, eosinophils, and basophils. And cytogenetic analysis will show Philadelphia chromosome. So an example is given: a 44-year-old male presents with fatigue and otherwise asymptomatic. So you can see that the only presenting complaint in chronic leukemias is a non-specific symptom such as fatigue. Otherwise, patient is asymptomatic, and his full blood count, it shows anemia and a raised WBC count. WBC count is 133. So mild anemia and raised WBC counts, and peripheral blood shows all stages of maturation of neutrophils, eosinophils, and basophils. So high WBC count and differential count shows increased granulocytes, and a peripheral blood film show all stages of maturation of granulocytes. Our diagnosis is chronic myeloid leukemia. So this is one way by which a question of chronic myeloid leukemia will be asked. And the second one is massive splenomegaly. Someone with a high WBC count and massive splenomegaly, your diagnosis will be CML. So these are the two presentations with which a patient can present to you. So let's do another example. A 51-year-old male presents for checkup, pale conjunctiva are noted. So again, pale conjunctiva means anemia. On examination, there is massively enlarged spleen. The fluid blood count are as follow. So there is mild anemia. WBC count is 65, that is raised. So someone with a raised WBC count and massively enlarged spleen, the diagnosis will be chronic myeloid leukemia. So these are the two ways by which a question of chronic myeloid leukemia can be asked. This is a peripheral blood which is showing granulocytes at all stages of maturation. These are blasts, myelocytes, metamyelocytes. This is one stage of maturation. This is a mature neutrophil. These are other stages of maturation. So peripheral film showing granulocyte at different stages of maturation. Your diagnosis will be CML. Again, another example, a 50-year-old malaise and tiredness, again mild anemia, features of mild anemia, and splenomegaly reaching the right iliac fossa. So a spleen that is reaching the right iliac fossa is a massively enlarged spleen. The other hint is also given, that is blood smear show granulocytes without blast cells. So the diagnosis is CML. Massive splenomegaly is either CML or malaria in Plab, and malaria would have a history of traveling. So in short, high WBC count with granulocytes on peripheral smear without blast cells, or high WBC count with massive splenomegaly is CML always. This was all about CML. This is clear, everyone, or is there any question?
Is there any age specific for CML or CLL?
Yes. Specific age for CML is that